Irritable bowel syndrome is an intestinal disorder that affects the large intestines, causing cramping, abdominal pain, bloating, gas, and even diarrhea or constipation. Now, IBS is not IBD, that inflammatory bowel disease, which is the inflammation of the bowels, as the body's own immune system is attacking itself. Common diseases include UC, or ulcerative colitis, as well as Crohn's disease, which we cover in detail in another video. Now, the key point is patient education for both IBS and IBD here. So write this down. We need to keep a journal of the symptoms, as well as the diet, and key term here, stress levels. And number 2, perform exercise 3 times per week. Now, the big difference here is the diet. So diet for IBS, we want to increase fiber and fluid intake. So Kaplan mentions, the priority instructions for a client with IBS is to increase fiber intake to at least 30 grams per day. Next, we want to limit or reduce intake of gas-forming foods. Number 1 that's tested is legumes, or basically beans, but also eggs, dairy products like yogurt was another commonly tested one, as well as fruits. And lastly, we want to limit or reduce alcohol or caffeine intake. Both of these guys cause an increase in gastric motility. Now, a top missed NCLEX question here. A client with irritable bowel syndrome, which meal choices demonstrates correct understanding of diet guidelines? Select all that apply. So option number 1, beans. No, we have to avoid the beans. Option 2 is correct. Yes, cornbread is okay. The key term in here is bread. Now option 3 is fruit salad. No, we always want to avoid those fruits. And option 4 and 5 are correct. Steak is a good protein choice here, and tomato basil soup. Remember, soup always soothes the bowels here. And lastly, option number 6, yogurt with granola. No, remember, no dairy. So the key term here is yogurt. So avoid the dairy here. All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the study guide. A small bowel obstruction is the blockage in the small intestines, caused by both non-mechanical obstructions as well as mechanical, with mechanical meaning that there's something physically blocking the GI tract. So for causes and risk, non-mechanical obstruction is from a paralytic ileus, fancy words for a paralyzed bowel. Everything stops and the bowel can die, typically after GI surgery or even opioid use, which makes everything low and slow, especially inside the bowels. And mechanical obstruction, which is that physical blockage from adhesions like scar tissue from surgery, even from hernias, and intussusception, where a part of the bowel gets stuck into another, kind of like a telescope. And also from tumors, from cancer, and volvus, basically just the twisting of the bowel. Now, when a bowel obstruction occurs, it develops with both gas and fluid collecting above the site of obstruction, causing a lot of pressure. Kind of like a fat kid getting stuck in a water slide. Like that chubby kid in the movie Willy Wonka and the Chocolate Factory who gets stuck in that chocolate tube. This is not good. So naturally, we hear hyperbowel activity above the site of obstruction and hypobowel activity below the site of obstruction. So signs and symptoms of a small bowel obstruction develop faster than a large bowel obstruction. This is because small bowels are smaller, allowing for more rapid obstruction. So the key point for a small bowel obstruction is rapid onset. So write this down. Frequent vomiting and nausea, as well as abdominal distension, described as colicky, or basically intermittent abdominal pain. Remember, it's a rapid onset, happening quickly. And again, bowel sounds. We hear hyperactivity above the obstruction and hypoactivity below the obstruction. Now, don't let the NCLEX trick you here. Not constipation or lack of flatus, or basically passing gas, which are typically late signs and more common with large bowel obstructions, which develop slower. and not painful pooing or defecating. This is common for rectal problems like hemorrhoids. As for complications, just think of the patho here, like a fat kid getting stuck in the water slide. We have a lot of pressure building up behind this small bowel obstruction. It's kind of like a ticking time bomb. The bowels can explode all over, leading to a perforated bowel, which eventually leaks into the peritoneal cavity, causing peritonitis. Again, this is a medical emergency, very deadly. We cover it in all the lectures pretty much in this GI series. So the NCLEX tips, once again, look for fever, tachycardia and tachypnea, as well as abdominal distension. And a key term here is a rigid board-like abdomen. The client needs immediate surgery or they will die from septic shock, that infection all over the body. So a common exam question. A client with a small bowel obstruction suddenly develops tachycardia, tachypnea, and high fever. What is most likely the problem? So option 2 here, a bowel perforation. You must notify the HCP because this client needs immediate surgery or they will die. All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the study guides. And also feel free to share the love, share with a classmate and even your instructor. See you guys in the next videos.